Good morning, everyone. Today, I'd like to share two real-world cases that shaped my approach to anti-VEGF therapy, not just in terms of treatment, but also in terms of clinical decision-making. Here is the first case, a 49-year-old female who came to the OPD with decreased vision in both eyes, visual acuity of 612, the anti-segment findings were within normal limits. She was a known case of glaucoma and under treatment and a recently diagnosed diabetes. Fundus examination revealed bilateral diabetic macular edema, presence of hard exudates inferiorly, and presence of NVE and NVD, which were further confirmed on OCT and angiography findings. And the case was labeled as a bilateral proliferative diabetic retinopathy with diabetic macular edema. So I did, usually in such cases, I go with the PRP first and then followed by intravitreal injections. I chose aflibercept here. I do not give any loading doses. I went on directly with the PRN regime. And what we observed was the rapid improvement in vision following the initial treatment. Visual acuity improved to 6.6. The retreatment criteria here was an increase in central foveal thickness of more than 20%, or a decline in visual acuity, or the presence of an IRF or NSD. So under a PRN regime, the patient remained stable, and even with extended injections, the stability was maintained for about 16 to 20 weeks, which was very good. Despite minor fluctuations throughout the period, I saw that I did not change the course of treatment. And over a period of 4 years, with repeated injections, I achieved a normal ellipsoid zone, normal foveal contour, and a maintained 6.6 visual acuity. And the interval between injections was approximately ranging from 16 weeks to 22 weeks, which was a very good case study for me. So overall, I injected around 10 injections in the right eye and 9 injections in the left eye over a period of 4 years. So what worked here was a good anatomical and functional response post PRP laser and anti-VEGF therapy. PRN maintained stability over longer intervals, that is around 16 weeks to 22 weeks. What is interesting is, despite extended intervals, the vision remained stable. It also suggested that the patient was a good responder phenotype. What I changed or considered is I did not switch despite having recurrences, and I continued the PRN regime due to a sustained response that I got. So not all DMEs require aggressive fixed dosing like a 3 loading doses followed by PRN or TREX. In selected patients, PRN can safely extend to even more than 4 to 5 months. Compliance and OCT monitoring is the key in this case. The second case is a different case. Again, a 49-year-old female entrepreneur came to my OPD for a routine examination. She said that my left eye vision had dropped, but on examination, her visual acuity was 6.6. Anterior segment findings were within normal limits. Intraocular pressures were normal. The right eye fundus was normal. The left eye seemed to be normal. As like many of us do, the initial thought was reassurance. There is nothing wrong with you. But the patient said, "Sir, I'm serious." So that's when I paused, decided to reevaluate, did a OCT scan, and on deeper assessment, I found that there is some subretinal fluid with PEDs there. So that was my reaction. And then I went on for reassessment, and there I found that there was a PED indeed, with some drusenoid deposits nasal to temporal to the disc. Again, the infrared and the autofluorescence imaging showing the same, with hyperfluorescence around the macula, showing presence of SRFs. And I went on with an angiography, FFA plus ICG, and I could see beautiful polyps just beneath the PED, which were active and leaking. So my diagnosis changed. Right eye was absolutely normal. These were the polyps under the PED. And the diagnosis changed to peripapillary exudative PCV. So the treatment options we have is a PDT or PDT with some anti-VEGF monotherapy or aflibercept. So I chose aflibercept monotherapy. Went on with giving 3 loading doses of aflibercept on a monthly interval. The vision improved to 6.6. Patient was happy. The PED regressed beautifully. The polyps also regressed beautifully. This can be seen on the serial OCTs that I have shown here. Post the loading doses, there was remission for almost 4 months, and there was activity after that, for which I again injected 2 more injections. But to my surprise, the PED did not come down. The SRF was increasing. So I paused here and I thought whether injecting is the way to go or I should do something else. I went on with an angiography, and to my surprise, there was a CSR leak which was right above the PED, which showed that this was not just a case of PCV anymore. It was a pachychoroid spectrum with an active CACR component.
Can you summarize, please?
So as a reflex, you usually tend to inject and not re-evaluate the case. So here, when I started the patient on eplenorol, the SRF regressed. Post that, injections worked for around 16 weeks on and off. And we have a remission period for almost 48 weeks in this patient, which is very rare in cases of PCV. So not all SRFs are VEGF driven, and pachychoroid spectrum requires our different kind of thinking. When the response always over and
Hatred. And life and your wish, but it ends. But in past, every rock can help up and say, so we need to talk at the end of the session and have like like just conclude.
Thank you very much. A lovely audience, very good speakers, amazing interaction, and very good panelists. But I would like to introduce Jeet here. I almost don't recognize him because I know him only on phone. Jeet Kariye. And his father is my friend, with the white hair license. Catch him walking in Kamati Bagh. So thank you very much, Jeet. It's been a pleasure having you, for taking the time, for looking at our cases, the works. We would like to give you a small memento.
Thank you, ma'am, for inviting me here. Thank you.
Your father is going to be very proud of you.
So we come to the end of the UVS session, and I would like to thank all the panelists, and we move on to the surgical session. I would like to invite Dr. Manish to take over the session, and Dhanashri and Sangeet, you can be on the stage as one of the panelists, and I have Kaushal, Mukesh, and Parth as more panelists, and I would request Kamar sir as our mentor. Please come in the front, sir. Please, sir. Come here. I am not going to ask you questions, but we would like to have you come in front, sir.
Dr. Ji.
Doing it from here is better. Yeah, showing or not. Yeah,
Yeah.